putting together in the same sentence Alzheimer's or dementia and reduction. In fact, you would probably expect people throwing you shoes if you were talking about risk reduction and dementia. However, some good progress has been made in the last few years, and this allows us now to be able to discuss this topic. And almost in every single conference that you go these days on dementia, there's always some room for this type of presentation. It is now, so just going to the big screen, it is now 116 years since this photograph. And this photograph belongs to Auguste. Auguste was the first official case diagnosed with Alzheimer's disease back in 1906. She was 55 when she died. And when she died, Dr. Alois Alzheimer's examined her brain, and he presented his findings in the Southwest German Medical Forum. And he presented the case as a peculiar severe disease process of the cerebral cortex. Unfortunately, nobody paid much attention to his presentation. However, what happened after 116 years? Well, after 116 years, what we have is over 50 million of people worldwide affected with this condition, and over 50 million of families affected with this condition. By 2030, we're expecting that number to go up to over 80 million, and by 2050, that number will be around 150 million. The last time we have a new drug released to treat Alzheimer's was back in 2002. We haven't had any new drugs since. I've been practicing in this field for the last 22 years, which means that for the last 20 years, I have not had the opportunity to offer my patients any new treatment. I cannot see any other area of medicine where such a lack of progress has taken place. However, you know, the arsenal, the drugs armamentarium that we have is just the same. Since 1996, we have 3 drugs that we're offering for mild to moderate dementia. And we have significant frustration because we cannot really offer any disease-modifying drugs to our patients. Why is that? Why we have made such a little progress in this field? Well, because Alzheimer's disease is a rather challenging, complex, heterogeneous disease. I like this definition of a multi-decade combination of dysregulated pathways, all leading to neurodegeneration. What that means that this is a disease that develops over many, many years. And it's the result of different processes taking place at molecular, at cellular level, at tissue level, that all end up causing the damage of the brain cells. To make things more difficult, each individual who has Alzheimer's has a different set of causes that has caused the disease. So when you see one case of Alzheimer's, you have only seen one case of Alzheimer's. Every single person is different because every single person with Alzheimer's has developed the disease with a different combination of causes. The risk factors are identified throughout the life course. So they are not concentrated in one particular stage of your life. They are spread along your life course. Some of the risk factors are more determinant in a particular stage of your life and also depend on whether you are a male or female or whether you carry the ApoE genotype. All these interact. There's an interaction between your genes, your gender, and the environment. So the window for our intervention is not the same for everyone. So that traditional model of medicine where you have a single pathology which you treat with a single equal type of treatment, you know, you have pain, you offer a painkiller, hoping that everybody is going to respond to the same painkiller. Maybe you need a different dosage, but everyone will respond to the painkiller. Or if you have a bacterial infection, you will respond to an antibiotic. That does not apply to Alzheimer's. One size does not fit all in this case. It is difficult to detect because it has a very long preclinical stage. That means that it has a long window where you may have already been developing pathology in the brain, but you don't have any symptoms. We have 100 billion of brain cells, and it takes at least 80% of those brain cells to be damaged before you develop any symptoms. So you can have, as I say, a very, very wide window of up to 30 years where you may be developing the disease without any symptoms. Again, have we been barking up the wrong tree? Have we just been concentrating all the efforts in research just looking at the amyloid hypothesis. The amyloid hypothesis is the more accepted hypothesis, saying that, which postulates that amyloid aggregation is the primary cause of Alzheimer's disease. However, we know that even when we remove the amyloid plaques, we don't seem to see an improvement in cognitive decline and functional decline. So maybe the amyloid is not the answer. Maybe the amyloid is just a risk factor, but not the cause of the Alzheimer's. So lately we have been looking into other areas like the tau protein. Should we be removing the tau protein to see if there is any improvement in cognition and there is any improvement in the function of the person? We also need more funding. The funding in Alzheimer's research is still very, very small when you compare to, for instance, to cancer or heart disease, but we also need larger and longer studies. Often the endpoints that we're trying to demonstrate in research is how good is this drug to help with the memory and how good is this drug to slow down any functional decline. Those two endpoints often are very difficult to measure in terms of time. You do need a very, very long period of time to see if they actually help. Another area where obviously we've been probably not doing very well is that for many decades, we've been testing drugs in patients who already have symptoms of dementia. Maybe that was too late. We also need beta predictive models, beta predictive algorithms where we can see who is most likely to progress to dementia and who is also most likely to benefit from the interventions that we offer. This is an infographic where I'm showing all the different processes. You don't need to really bother too much about this. It's just a way of illustrating how many different pathways can end up causing Alzheimer's. We have the metabolic system with all the, the lipids, with the glucose. We have the endocrine system with the hormones, the cardiovascular system, high blood pressure, high cholesterol, atrial fibrillation, strokes, nutritional deficiencies, the vitamin B and the vitamin B group, toxicity, environmental toxicity, toxicity from drugs, from fertilizers, from food additives, and then infections. All those pathways needs obviously optimizing. All those pathways need to be mitigated if we want to actually prevent Alzheimer's. How many roads take you to St. Helier every morning? There are so many roads taking us to St. Helier when we go to work every morning. You may close Victoria Avenue, but you can still access to St. Helier from the north or from the east. So you're not preventing people getting to town. The same with this. We may be blocking the metabolic system. We may be blocking the cardiovascular system, but we have so many other pathways that are still open. And who knows how many more pathways we don't know yet. We have not discovered yet. So this gives you an idea of the magnitude of the challenge that we are facing. And again, patients may develop Alzheimer's by having a unique combination of some of those. Some patients may have an Alzheimer's disease with a bit more of cardiometabolic or endocrine type of print. Some others may have Alzheimer's disease more because of the combination of cardiovascular toxicity and infection. That makes the whole approach very difficult, and it should be targeted if we want to have any chance of success. All those pathways that I showed in the slide before end up causing changes in the immune system, causing changes in how we utilize energy in the brain, and causing damage in the brain cells, which is what we call oxidative stress. And all of that end up causing inflammation of the brain. We say that Alzheimer's disease is a neuroinflammatory disease. A brain without inflammation may well be a brain without Alzheimer's. Alzheimer's disease has 3 stages. It has one stage, as I mentioned before, that is the preclinical stage, where we don't have any symptoms. We may already be developing pathology in the brain. And that is a very long window, 20, 30 years, often begins when we are in our late 30s, 40s, followed by another stage that is what we call mild cognitive impairment. In the mild cognitive impairment, the person is already showing some signs of memory or language or thinking changes, and is either reported by the patient or is reported by somebody who knows the person well. However, overall, that person is able to manage everyday activities reasonably well. And that stage, which could be around 5 to 8 years, often leads you to the next stage, which is what we call dementia. In dementia, we have pathology of Alzheimer's disease, but we also have symptoms. We have already symptoms in memory, language, and thinking to the extent of interfering with how you manage everyday life. I like this graph because this graph shows what's happening in the brain through all those three stages. And if we want to have any chance of success when it comes to preventing or reducing the risk of having Alzheimer's, we have to concentrate on the left side of that graph. We have to go as early, we have to move the needle as to the left as we can. Because once we have the amyloid, fine, the amyloid in itself is not going to cause Alzheimer's. The amyloid needs something else, we know that. The amyloid may be the bullet, but the bullet needs to be triggered. And the trigger is the tau protein. Once you develop accumulation of the tau protein inside the brain cells, then that is when the process of damage in the axons of the brain cells takes place. And that is when the damage in the structure of the brain starts to take place and you start developing symptoms. When we see changes in the MRI scan or in the CT scan, that is too late. When we can see those changes with our eyes, that means that the damage that has taken place in the structure of the brain is too significant, and that is not reversible. So we have to concentrate as early as possible if we want to have any opportunity to mitigate or to slow down the progression of the pathology or to slow down the onset of symptoms. Where are we now when it comes to research? I did say that we have a very, very high history of failure when it comes to researching Alzheimer's disease, no drugs for 20 years. And I know Dr. Emma McSweeney did a presentation yesterday about medication. Currently, we have around 121 therapies being tested as we speak in more than 100 trials. Most of these drugs that we are testing as we speak are disease modifying. So that means that there are drugs that can hopefully remove the pathology, whether it's the amyloid or the tau, and hopefully also improve the cognitive symptoms. There are also some drugs that have been repurposed. Those are drugs that were licensed initially for a different indication, but they are looking into whether those drugs could have an opportunity to work also in Alzheimer's. We are increasing the number of biomarkers that we are using these days that allows us to measure the disease. Something that we can do today that we could not do in the 1990s is that we can measure Alzheimer's. We have the tools to measure Alzheimer's, not just only through CSF analysis, but also through new biomarkers. We have new biomarkers like, for instance, neurofilament light chains. That is a very early biomarker of neurodegeneration, even earlier than tau protein. We can also do that. We can also check amyloid and tau through a blood sample, plasma sample. And we have more sophisticated functional imaging PET scans that allows us to see the functional imaging of the brain. There's also an increased diversity of targets. I said before, we may have been barking up the wrong tree for many years. So now studies, research is also concentrating in anti-tau proteins and also in gene silencing. So one of the messages I want to say is Alzheimer's is a disease of middle age. It's not a disease of all people. It's a disease that begins in our middle age and it manifests when we are older. This is a very busy slide, but I don't need to worry. What I want to say from here is that there's a study called Finger Study, which is a Finnish study published in 2015, which represents the before and the after when it comes to attempts to reduce the risk of dementia. Before the Finger Study, as I say, it was almost an act of bravery to be standing on a podium and talking about dementia risk. What people who were in the treatment group of the Finger Study, they demonstrated an improvement in executive function. Executive function is crucial when it comes to manage everyday activities. It's the set of cognitive skills that allow you to actually plan, sequence, problem solving, and organize your everyday life. And those patients improve in that. Also, they improve in processing speed of information. And the important thing is that the benefits from these interventions were the same regardless whether you were an ApoE4 carrier or no ApoE4 carrier. There are other studies like the MAPT that was done in France or the PREDIVA who was done in Holland. They all similarly, they all monitoring cardiovascular risk factors or supplementing the treatment group with omega-3. And the Predimed study done in Spain, combining the Mediterranean diet with supplementation of olive oil and nuts. Or group in United States, let's see if I can, or group in United States published a study also where it was not a randomized controlled trial, it was a comparative effectiveness study. And what we did is we have two groups, one group of people who have no pathology in the brain, or they have preclinical Alzheimer's, and another group of people with early Alzheimer's. And we gave them 21 recommendations, 21 interventions. And what we found is that people who have early Alzheimer's, who follow at least 60% of the recommendations made, did improve in their cognitive composite, and they also improve in the cardiovascular biomarkers. Where are we in terms of public awareness and public knowledge about what we can do to reduce our risk? Well, back in 2018, the I think it was the UK research. Yeah, the UK, the Alzheimer's Research UK did a survey, and the outcome was that half of the UK adults could not identify any key risk factors for dementia. Despite of all the access to media, information, 24 hours a day, half of the UK adults could not name a single dementia risk factor. And there were other findings in that survey. And only a third of the participants knew that it was possible to reduce the risk of dementia, compared to, I think it was 80, I cannot see the part of my, 81% who knew that it was possible to reduce the risk of developing diabetes. There was a higher level of awareness about dementia, but there was still a low level of awareness when it comes to what diseases or what risk factors contribute to the development of the disease. Well, this survey was repeated 2 years later. So we have now the outcome of the survey from 2021. One positive thing is that less people today believe that dementia is just an inevitable part of getting older. And that's an improvement in the last 2 years. Dementia remains the health condition feared by most, 48%, particularly among women and older adults. However, the awareness of risk factors for dementia remains very low. You can see only 3% of the participants manage to mention blood pressure as a risk factor, and 2% mention diabetes as a risk factor. Diabetes, type 2 diabetes, double the risk of Alzheimer's disease. Alzheimer's disease, well, high blood pressure and diabetes are two very strong risk factors for dementia. However, very few people knew that those two risk factors were key players. So more work needs to be done in this field. Also, other few findings were that only a third of the public think that it is possible to reduce the risk of dementia. And among them, women are less likely to think it is possible to influence the risk of dementia. However, 3/4 of people believe that they can do something about their brain health. So it may be down to how we phrase it. Do you think that dementia risk reduction puts people off? And brain health optimization is probably a gentle term, is more positive term. People will buy more into brain health, looking after my brain health, than buying into reducing my risk of dementia. So there is room for that consideration, whether we should be looking into the semantics. 3/4 want to understand better what is their personal risk of developing dementia, if the doctor could provide them with this information. So this is what could be a role for brain health clinics that are now being developing. In Jersey, as you probably will know, we embarked ourselves in a campaign of dementia risk reduction back in 2019. We have a one-day workshop where we invited different people to talk about how we could reduce our risk. And since then, we've been promoting dementia risk reduction in our clinic, not as much for our patients who are already displaying symptoms, but nevertheless, it's still important even for them to do anything they can to do what we call tertiary prevention, to try to delay the onset of complications. So it's never too late for anyone to learn about how to improve your brain health. This is also a message that we tend to share with the relatives and children who come with their parents to the clinics, to the appointment, and we start that dialogue with them about how to protect their own brain.
Juan, sorry, I'm terribly sorry to interrupt. Would you mind seeing if you could hit your slideshow button
yes,
at the bottom?
Yeah, let me see if I can. Yes,
that's the one.
Better, perfect.
Brilliant, thank you.
So that banner is standing in the corner of the clinic, and it's always a point of conversation. As soon as the people arrive into the room, we use that always as an anchor to initiate some form of dialogue about what we can do to improve our brain health, to optimize our brain health. Obviously, there are risk factors that we cannot modify, and we know that age is something that so far, despite of attempts, we cannot control. We get older, and as we get older, the risk of getting dementia increases. 1 in 6 people over the age of 80 have dementia. Another thing that we cannot control yet is the genes. Again, people who carry ApoE4 allele of the ApoE have an increased risk of developing late onset dementia. I mean, ApoE4 is the leading genetic risk factor for late onset dementia. Having said that, having 1 copy can increase your risk by 3-fold. Having 2 copies can increase your risk by 8 to 12-fold. But having said that, you can still somehow influence the expression of the gene through what we call the epigenetics. The epigenetics is how can you change the expression of the gene through changes in the environment and changes in your lifestyle. And there is some room for that. Another risk factor is the sex chromosome. We know that 2/3 of Alzheimer's patients are female. And we could be here all evening talking about why. And that means we know that the lifespan, even when we take into account the lifespan the different lifespan between male and female, or also the age-dependent mortality and the age and death, Women's Lancet Commission for Dementia published a paper in 2020 with recommending that if we were able to control 12 modifiable risk factors, we could potentially prevent up to 40% of cases of Alzheimer's disease, which means that there is some room for intervention. There is some room to influence on our chances of having dementia later in life. We know also through the CFAS-1 and the CFAS-2 study, which are 2 observational studies conducted in the UK, where they compare a number of cities in England 20 years apart. They could see that 20 years later, there was a drop of 20% in age-specific incidence of dementia. And the main reason for that was because there was a reduction in a smoking habit, but also because there was a better education, access to education, and improvement in how medicine is now managing heart attacks, heart failure, and strokes. This is the infographic showing the 12 modifiable risk factors that you can see. They are spanning across your life, and from early education through middle life with the hearing loss, the traumatic brain injury, high blood pressure, alcohol intake, obesity, and then later on in life, smoking, depression, social isolation, lack of physical activity, air pollution, and diabetes. I have also added here 3 risk factors which are not included in the Lancet Commission. One is chronic stress. Chronic stress, particularly the rumination. That chronic stress of rumination, there are studies suggesting that internal, that type of worry that people are not able to see, that rumination can cause significant damage in your hippocampi. Visual impairment. Visual impairment, probably the mechanisms of visual impairment and hearing loss are very similar when it comes to affecting cognitive decline. We know that it's a double whammy. If you have hearing loss and visual impairment, you have much pronounced cognitive decline. And there are studies now being conducted in Europe looking into that. And poor sleep. I don't have to say that poor sleep. Sleep is one of the main pillars of health. Sleep is very important when it comes to your physical health and your mental health. And it's crucial when it comes to consolidation of memory, when it comes to increasing the capacity to learn new things. And it's during the slow wave where we clear all the amyloid that has been accumulating during the day. So with all these studies, with all these recommendations, what the World Health Organization say that there is plenty of evidence been collected indicating that multi-domain approaches targeting simultaneously multiple risk factors and tailored at both individual and population level are likely to be most effective and feasible in dementia risk reduction. The Landsat Commission talks about prevention. The World Health Organization talks about risk reduction. Or a research group, we published this paper back in 2019 because even within our group, we have a bit of a disagreement on what we should be calling or consortium: risk reduction, prevention, Alzheimer's prevention clinic. I would always be more in favor of risk reduction rather than Alzheimer's prevention clinic. I mean, we had an Alzheimer's prevention clinic in New York. Now they are now reconsidering their name and becoming a brain health center, Center for Brain Health. And again, it depends. If you think that prevention means preventing a disease from happening, then obviously you probably cannot use that term when it comes to Alzheimer's, because we still not fully understand all the pathoetiological mechanisms involved in the disease. So you can, if prevention is your ultimate goal, your ultimate aim, then probably that's not the term that you should be using. However, if you use the World Health Organization definition of prevention, then you have primary prevention, which means preventing pathology or disease from happening. Secondary prevention, which is early detection of the disease or preventing symptoms developing. And tertiary prevention, which means preventing disability, preventing complications. So in that sense, yes, you could be using it. I like the term risk reduction more, as I say, more than prevention, because you can treat risk factors all along your lifespan. You can treat risk factors along your life course, hoping that, or aiming that you might be able to do at least secondary prevention. Again, should we be talking about brain health or risk reduction? I think we are heading in the direction of brain health. I think I can see that from Alzheimer's prevention down to risk reduction. You can see our campaign in 2018, we call it risk reduction. If we have to do it today, I will call it brain health promotion or harmonization or whatever. I will be moving towards that brain health. Why? Because brain health is critical when it comes to a good general health and good mental health. Brain health is the centerpiece. Brain health, again, it encompasses all the stages in your life. It's from birth. It's even, brain health is even before birth. It's when parents are deciding to have a child. It's their attitude towards parenting. It's their attitude towards what education we're going to give our child. What chances are we going to give and opportunities to our child? It also includes the antenatal. How is the mother, what are the mother's habits during pregnancy? Smoking, diet, alcohol, It's about preventing the mother developing diabetes during pregnancy. It's about preventing the mother developing postnatal depression. It's what opportunities are we going to give the child when the child goes home, and what opportunities are we going to give when he goes to school? How is that child going to, what is his disposition or her disposition to learn? And it goes along and along through your, schooling and your workplace, and how you establish relationships, how you manage frustration, how do you build that resilience? So it's a lifelong concept. While risk reduction is much more circumscribed to reduce the risk of developing a particular disease. So I do prefer brain health instead. And again, includes mental capital, includes the concept of mental well-being and mental health.
Yeah. I'm afraid we've reached the end of time.
Sorry. There are increasing number now of brain health clinics being developed in the United Kingdom. The first one was opened in Edinburgh in 2020. And now we have 4 or 5 more across the UK, looking into how they can identify the individual risk factors for that particular person, how to do early disease detection in the brain, how to detect early expression of the disease by doing cognitive testing, and based on that, give you a targeted prescription of interventions, particularly for you based on your risk factors. I will probably, obviously, these people who go there are people who are well-informed, people who are willing to change, people who are willing to take control of their brain health. This is something what we do in the United States in our brain health clinic. Again, includes a very expanded clinical history, examination, and all forms of biomarkers I never heard before. I took part of this group. We put them through an algorithm of risks and prediction, and based on that, we come up with a very bespoke prescription of interventions for that particular individual. To make things more difficult, again, one size doesn't fit all. So if you are, again, you have a person who is a female ApoE4, who smokes, who is diabetic, who doesn't have who doesn't do any exercise, and who drinks too much alcohol, that person's individual risk is going to be completely different to somebody who is no ApoE4, for instance. So ApoE4 is very important when it comes to see how some of the other risk factors, alcohol, smoking, sleep, high cholesterol, can be more, can have a more impact in your brain health than in somebody who is no ApoE4. Again, the protection of the brain health begins outside the brain. It's like playing chess. You're protecting the king and the queen through your rooks, through your pawns, through your bishops. The same, the brain is up there and it has to be protected. It's protected by the blood-brain barrier, but also has to be protected by having a good digestive system. It's important to talk about the microbiome. That is a very important subject now, very interesting to follow. The microbiome has a very important role when it comes to protect your brain, because you have the wrong balance of bacteria, you can have a leaky gut, inflammation can get through your lining of your gut and it can get to the brain. You have to have a good, healthy heart and arteries that can send blood to your brain. And you need a good metabolic system that can really break down the food and the nutrients in the brain cells to produce proteins and energy. But also important to have a good oral care. How neglected is the oral care? Oral care should be also on the top priority of when it comes to brain health. Again, what can I do from today? What can I do? That's what people say to me. Okay, well, let's introduce realistic changes. Don't be too ambitious. Start today with what you can change today and start from there and get to know your numbers. Go to see your GP and say, look, can we start this dialogue about brain health? Can I check my, well, I'll check my weight, I'll check my waist circumference. What is my blood pressure like, my cholesterol, my sugar, my kidney function, any biomarkers of inflammation, the CRP, my vitamin B, my vitamin D, B group, and what is my heart rate? What is my pulse? Is regular or irregular? We know that irregular heartbeat, atrial fibrillation can increase the risk of stroke by 5% per year. It's a cumulative effect. And it can also increase the risk of Alzheimer's disease. And again, what we want ultimately is to avoid developing chronic diseases. We want to avoid chronic diseases and we want to avoid inflammation, because inflammation means Alzheimer's. This is a draft. This is I did a pilot document a few years ago, before pandemic, before COVID hit, of what should be a brain health check document that we could be using if we had the resources. We could just, again, we could go to the surgeries, sit down with the GPs and see if we can get, patients to establish this dialogue about brain health. They are very evidence-based questions, and we have also evidence-based biomarkers that are quite easy to check. There's nothing there apart from the fibrinogen or homocysteine that couldn't be done locally. And this could be reviewed as they do with the NHS health check every so often, 3-5 years down the line. What can I do? Be physically active, move more, combine cardio exercise with resistance training. Cardio exercise is going to increase your blood flow into the brain. Resistance training is going to expand your brain cells, is going to have a neurogenesis effect. It's going to expand your hippocampi. Stay cognitively active. Be curious, find out what's going on, learn new things. Take some responsibility. Even looking after your dog requires responsibility. And that sense of responsibility is so good for your cognition. Maintain a healthy diet. Fruit, vegetables, legumes, whole grain, omega-3, olive oil, all together with exercise. That is the thing. That plant-based diet with exercise has a synergistic effect. Move away from processed, ultra-cooked meals and go for fresh food, organic. And if you eat meat, it should be grass-fed and not add any additives to your food. Avoid food with additives or any artificial sweeteners. Artificial sweeteners are going to increase your weight, increase your risk of diabetes, and it's going to affect your microbiome. It's going to damage your bacteria in your gut. Avoid refined carbohydrates. Go for complex carbohydrates which have low absorption, low glycemic index, and high in fiber. And how not? Correct your hearing loss. And particularly the subclinical and mild hearing loss in middle age. We know that that subclinical 20 to 40 decibels of hearing loss are the ones that are making people in middle life more likely to develop cognitive problem later. We now started in the memory clinic screening hearing loss. We have a device, a hearing loss screener, and we started now to check and screen for hearing loss in the memory clinic. Optimize your cardiometabolic risk factors, high blood pressure, the typical suspects, diabetes, heart failure, atrial fibrillation, and obesity. Again, good oral hygiene, brushing twice a day, flossing at least once a day, and non-smoking. Go to the oral hygienist every 6 months and have your annual check with your dentist. Pay attention to your sleep. Again, basic. Find ways to manage your stress. As I mentioned before, chronic stress, the cortisol levels, the sustained high cortisol levels are killing us. Cortisol is pro-inflammatory. Cortisol can damage the gut. Cortisol can increase the glucose and cause insulin resistance. A special consideration to the perimenopause. That is another area of special interest for me. Perimenopausal ladies who have symptoms of hot flashes, foggy brain, they cannot sleep, they have, mood swings. Those are neurological symptoms. Those are not ovarian symptoms. So therefore, we should pay attention to those changes, because menopause is like refurbishing your brain in an already established network of cells. So it's a really tricky stage in your life because some damage can be left. Reduce your alcohol intake. There is no safe amount of alcohol when it comes to brain health. Protect your brain from head injuries. Meet people, socialize, find out what's going on around you. The last question, Matt, can we prevent Alzheimer's? The answer is yes. In 40%, potentially in the 40% of cases, yes. In some of the cases, let's be quite honest, we may not be able to, but we may be able to delay the pathology in the brain and delay the onset of symptoms. So we may be able to move you from the fast lane in the motorway heading towards Alzheimer's and put you on the left slow lane. So you may get there 10, 15, 20 years later. And that means a lot until at least we have a disease-modifying treatment. In other cases, we may not be able to prevent you from developing dementia, but we may be able to prevent you from developing other comorbidities like heart disease, stroke, diabetes, high blood pressure. And please take responsibility of your brain as early as possible, as we take responsibility for other parts of our health. And the health of our brain depends on how we live more than on our genes. And that is me.
Thank you
so much for listening. And I have to really speed at the end to go through the slides.
No, well, that's absolutely brilliant. So thank you very much. I'm afraid we are going to have to push on, but Juan, there are a few questions that have been posted in the chat. If you're happy to stick around for a little while and perhaps answer them directly in the chat, that would be brilliant.
No worries.
You should be able to see them. But Juan, that's fantastic. Thank you very much.
It's a pleasure. Thank you so much, everyone.
Dan, are you able to take back the screen? That's grand. Well, after that, a very contrasting thing. Our next speaker, Peter Berry. Peter was diagnosed with early onset dementia at the age of 50, and he's become an extremely powerful advocate for people with dementia. He's written 2 books on the subject with the help of his cycling colleague, Deb Bunt, and I'm thrilled to say that Deb has joined us this evening, though I'm not sure if she is on the talk at the moment, and hopefully, Deb, you'll be able to stay around because Peter has recorded his presentation, but Deb is here to be able to hopefully answer any questions afterwards. So, Dan, would you be able to start the presentation?
Hello, everybody, and I'm very privileged to have this opportunity to speak to you all today. I suppose really I would have loved to have been there in person, because I find talking to people in person so much, I don't know, so much easier than talking to a screen. But things being what they are, we have to go with the wonderful use of technology. So today I want to talk to you a little bit about living well with dementia, what it's actually about, what living well with dementia really means. I suppose also how I got to this place of living well with dementia, and a little bit about my journey, our journey as a family, and the journey that I think my friends go through as well. So my name is Peter Berry, and I was diagnosed with early onset Alzheimer's at the age of 50. Having a diagnosis of Alzheimer's at that age group is somewhat different to having a diagnosis later on in life. I suppose my perception of dementia was very different to the reality, and I think that's the same for just about everybody. And it's not until you experience this that you fully understand the extent, and I think the way that it affects lives. So I was running a successful timber business. I was doing all the things that people do in business, rushing around like a lunatic, earning money, and I was doing okay. The business was successful, and I always had a very good memory for the work that I did. To give you an example, people would come into my sawmill and they would discuss a project with me, and they might come back probably 8 months, if not a year later, and in some cases even further than that. And I would remember the project. I would have an idea of who they were. I could fit them to the project very easily. I wrote very few notes down. I had everything inside my head. Over a period of time, that started to change. My memory got worse, and over time I found it very difficult to run the business, even though at that time I didn't really notice it so much. My wife came in the office one day where we had adjacent to the house, and I had post-it notes stuck all over the table, I think, and on the wall, and that reminding me of different things that I had to do. That's when she realised that something was seriously wrong, and we needed to take this further. It took a few years to get a diagnosis. I think I'm right in saying about 2 years, I believe. And eventually we got the diagnosis of early onset Alzheimer's through various tests and scans. I do recall going into the doctor's surgery and being there and sitting in front of the doctor and having a diagnosis which took approximately about 10 minutes. And we left there just with a leaflet and not much else to go with. Now, I think things have changed since that time, and I think over the last few years the process has, from what I can understand, become better, and I think the support is better. But at that time there wasn't much. My life changed within that 10 minutes of diagnosis. And I think that looking back on it, I come to think about this a little bit. Why did my life change? Why did my life collapse over 10 minutes? I walked out of that surgery a completely different person. As far as I was concerned, my life was over. I wasn't going to do the things that I had been doing. What I heard was, you can't cycle, you can't walk, you can't run, you can't work, you can't do these things. That's sort of what I heard, and that's what I believed would happen. Now, looking back on that, that was completely wrong of me, because I come to realise now that I was no different when I left that surgery than I was when I went in at 10 minutes beforehand. I was exactly the same person. It's just somebody had told me something. Somebody had confirmed something, and that's what changed everything for me. Over the next year, things did change, and things did, I suppose, go from, how can we say, bad to worse. I got very depressed. We didn't tell anybody about our diagnosis for the first year because I suppose I was ashamed, embarrassed, worried. There was all of these emotions going on. And we didn't really know where to access support, really. It seemed that all the support was tailored to older generation, people above retirement age. There didn't seem to be a lot for people in my age who was physically active. I was able to do things, and I still am. I think it was really at the lowest point ever possible that I realised that nobody was helping us, and that me as an individual, I could help others. And I think I had to go through that journey of depression and go to the places where I don't think anybody should really have to go in their lives to actually realise that. It was at that point that I realised that I had a sense of purpose again. Dementia had taken so many things. It had taken my business, it had taken my driver licence, it had taken my independence, it had taken many things through that year. But I was able to take something back. I was able to achieve something. Because I knew what it was like, we knew what it was like as a family to be in this situation. How many other people were going through this journey? How many other people were going to go through that journey? How many other people had gone through it and probably hadn't done very well with it? We could help them. So that's what we did. Now, living well with dementia can be many different things. For me personally, it's cycling. That's the thing that does it for me. It doesn't have to be cycling. It can be simple things, walking, gardening, swimming, even just having a cup of coffee or a piece of cake with your friends and having a laugh. But it took me a whole 12 months to understand that and to realise that. So I come up with this idea of helping others by showing people that you could live with dementia. Life wasn't over. It was just going to be a bit different. And we needed to show people that different wasn't all bad. So I decided to do a challenge every year, challenge myself, challenge my dementia, and I suppose just challenge life, really. And the first thing I did is I cycled from Wales back to Suffolk. I think it was 360 miles. We raised some money for dementia charities and raised awareness. That was the first thing. And I think that during that actual cycle trip, I realised what for me living well with this condition was. It was just riding a bicycle. The simple act of riding a bicycle. Nothing complicated, just getting on a bike and riding it. It was at that point that I realised how complicated dementia was, but also it was surrounded by simplicity, and the simplicity for me was the bicycle. So many people try to work out the complicated parts of dementia. I've learned over the years. They try to work out what people are thinking. Why has somebody forgotten this? Why doesn't somebody recognise me? Why? Instead of just trying to look at the simple parts of dementia, the bits that make the complicated bits less complicated. An example of that is my father had Alzheimer's, and when he was in a care home, I used to go and visit him quite regularly. Sometimes he wouldn't know who I was. I didn't try to explain to him that I was one of his sons. I didn't try to explain to him that I was Peter, because he had a brother called Peter. That would have complicated things, and the Peter wouldn't have been my age. Peter would have been 5, 6, 7 or whatever age. I just became a friend of his who spoke to him that day, at that time, about the stuff that he wanted to talk about. I knew his history, so I could talk to him about his work, his past. And that all worked for him. And we would have a laugh. And that somehow made his dementia less complicated. And that's what cycling for me did. My wife never asks me if I go out for a cycle ride with my friend Deb where I've been. She asks me if I've had a good bike ride. And that is simplifying it, because I can't often remember where we've been. So that was my beginning of living well with dementia, cycling across the country. And after that, I thought, yes, I'm going to do something different every year, if I can find something different. The following year, I did do something different. I cycled 5 counties of Great Britain, and I think it was Suffolk, Cambridgeshire, Essex, Lincolnshire and Norfolk, I believe it was, on a penny farthing. Just because it was something different. It was a challenge. It wasn't just a man with dementia riding a bicycle. It was a man with dementia riding a penny farthing. Now, I didn't do any of the organisation. Other people did that for me. And basically all I did is just sat on a bike and followed those people in front of me. And we raised lots of money and we raised lots of awareness. And it shows people, I'm trying to show people that I suppose living with this condition is not easy by any stretch of the imagination, but it is doable. I'm just a normal guy. I just do normal stuff as far as I'm concerned, and if I can do it, so can a lot of other people. Now, my short-term memory is not that good at all. And to be perfectly honest with you, to give you an example of that, today I'm talking to you and it says on here that I've been talking for 11 minutes and 30 something seconds. I can't remember what I have spoken about. I've got a rough idea, but I can't remember the flow of it. It's as though whatever I've said has been rubbed out, I suppose, erased from the page, if you like. So today, to help me, I have my friend Debs, who sits beside me here, my really good friend, who will just give me a little prompt, because being me as I am, and this condition, it means that I lose the thread.
Restaurants that makes mistakes?
The restaurant that makes mistakes. You see, all of these things that I have done that I just purely forget, they just go from my head until I'm prompted. We were contacted, the family were contacted by Channel 4, and they wanted to do a programme about people with dementia. People with dementia, I suppose, in the workplace. And the idea was that we ran a restaurant in Bristol, and we ran it for quite a few weeks. We did 1 sitting a day, I think, and there was 14 of us with all types, different types of dementia that ran this restaurant. And I know it is still available, I think, on YouTube, and I think if you put in the restaurant that makes mistakes, Channel 4, it will come up, so you can see clips of it. It was a great experience. It was an experience that I wasn't sure whether I wanted to be part of or not, but when we actually got the invitation and we went through and we started the whole procedure, it was actually absolutely wonderful. One thing that we had, all of us, I think, with dementia, and one thing that we hadn't had was peer support. I hadn't been around many people in my own age group with this type of condition. And it was really good to be with other people who had the same condition, but it affected them differently. Some people it affected, like me, my memory. Other people it affected their mobility. Other people it affected their speech and eyesight and that sort of thing. But together we coped and we made a very, very good team. We ran the restaurant for quite a few weeks, and we wanted to show people that, well, show the public really, and businesses as well, that people with dementia could still achieve. We still had a purpose. I ran a business for all those years and I could still somehow manage people a little bit. I believe there was a guy who was a plumber and he could still do plumbing. He could still do that. And we want to show people that we could still achieve. Yes, we made a few mistakes, but it worked. And it was a really, really good opportunity to, I suppose, change people's perception of dementia. I don't think we had a bad plate of food come out, and I don't think we had any complaints. I think people were all satisfied with what we achieved. And I do believe that as a direct result of that, a few of the people who were involved actually managed to get a couple of days' work a week, with companies around the Bristol area, which was a great thing, because it seems that employing people with dementia in my age group seems to be a very difficult area to get into. Companies are supposed to, I suppose, be aware of people's disabilities, and companies will change things for people with wheelchairs and various other disabilities. But when it comes to any type of dementia, we don't really get a look in. And one of the key problems is that people in my age group, we're not retired. We end up getting this condition and not being able to work. The benefit system is tailored to an older generation. Because we're physically fit in most cases, the system thinks that we can work. But trying to get a job is a different thing altogether, because nobody will employ us. Or that was my experience in this area. I was lucky because I do have a private pension, but not everybody has that luxury. And finances and earning a living in our age group is one of the things that is somewhat overlooked. It is something that people tend to forget about, because only old people get dementia, only people in care homes, only people retirement age. That's the perception. But the reality is very, very different to that.
Do you want to backtrack and talk about your Dementia Monster and how that helped?
My Dementia Monster, yes, yeah, that's another good thing. When I was diagnosed, I found it difficult to cope with something that I couldn't see, something that I couldn't physically hold, something that I couldn't physically, I suppose, deal with. It was something that was in my head. It was really just a scan, just a doctor speaking to me. And I had this idea that somehow if I took dementia out of my head and created it, made it into something, I could deal with it better. I could somehow, I don't know, live better with it. So I created my little Dementia Monster. And I believe there's a picture of him in one of our books, and Debs is now going to find that for us. Here we are, yes. There we are. I hope you can all see that. My little Dementia Monster. He's quite ugly, he's quite bad-tempered, he's very cross, and he is always in control of my life, except for when I go out cycling. And we get back to this simple part of dementia again, because cycling gets me away from that Dementia Monster. I become Peter, the cyclist, not Peter with dementia. And I come to realise that when I was away, my Dementia Monster, I had this little image of him sitting on the settee at home, twiddling his thumbs, very cross, very angry, very riled, that I was out doing stuff and he wasn't in control of me. And then when I came home, I could somehow accept it better. So for me personally, making my dementia a thing, an object, something that I could actually physically do something with, somehow helped. I'm not saying it will help for everybody, but life is all about coping strategies. And just because we have dementia doesn't mean that we stop coping with things, or we shouldn't stop coping, because coping is one of the things that should actually keep us going. And for me personally, something as simple as that just works.
How long have you got?
19 minutes I've done so far.
So you could talk about support and where to find support.
Support, that's another thing that we had to learn about. Now, all of the big charities, they do some wonderful things. They support people with dementia, and they do some really good work. But we personally, as a family, found that support was closer to home. And we sort of stumbled across it, really, in a funny, weird way. And it seems to me that a lot of the solutions that I have come up with or come across through after being diagnosed have been stumbled across. We haven't somehow came up with them, we've sort of somehow found them. The charities, they support people, but they only know the person with dementia. So if I later on need more support and we get a charity, and that person knows me as the man with dementia. But support can be closer to home, friends, family, because people who know you, they know you prior to the dementia. Now, an example of that was my father in the care home. The people who came to support him only knew him as Jim, and they knew what had been written down for them. But I knew my whole father's life because he had told me, and I'd been around him a lot, I'd worked with him. So I made his experience with the condition a lot easier for him because I knew everything about him. I could talk to him about things that carers or support workers wouldn't even know because nobody would tell them. So sometimes support is a little closer to home. Now, I don't really think I need a lot of support. A bit, but not a great deal. And cycling with Debs actually works both ways for me. My wife is, I suppose, satisfied and pleased that I've got somebody to cycle with, and she hasn't got to worry about me getting mislaid in the countryside. But also I get to show Debs the countryside, and that gives me a purpose again. That gives me something to do, something that I suppose I'm in charge of. The routes can be a little longer than we intend them to be, because sometimes a left turns into a right and a straight on turns into another left, but never mind, we get there eventually. And because I've been involved in bicycles all of my life, then I can still mend a puncture. I can still maintain a bicycle. So if something goes wrong, I'm the one who's in charge. I'm the one who actually fixes the bikes. So that gives me a sense of pride and purpose. Being as I was somebody who ran a business all those years, and then having all of that taken away, to actually have just a little something like that where, you know, I've got a problem here, Peter, can you sort it out? Yes, no problem. I sort it. That just gives me a sense of worth. And having that sense of worth is a very important thing. And I found that is actually, in a funny sort of way, key to living well with dementia. Having a sense of worth, being involved in things, not being the centre of attention, but being involved in conversations, being involved in situations. And yes, it might be here and now for people like me, but it's still so important to be involved.
And to finish off, you might want to mention
the books.
It's not an advert.
It's not an advert, no. During, I suppose, the few years that I've known Debs, she has put together little sayings and things that I've done. And I think it was never intended to be a book, but we ended up writing a book together called Slow Puncher, Living Well with Dementia. And it's about a year in, I suppose, my life. It's also dementia a little bit different as well. It's from somebody from the outside who knew nothing about dementia. Debs had no knowledge of dementia, came across me, and I think how it's also opened up her world, how she sees dementia differently, how I suppose dementia has changed her life, and how there has been some good things coming out of dementia as well. Yes, it is an ugly, terrible, dark place to be sometimes, but also we have to learn to laugh at our dementia. We have to learn to poke fun at it. And I think this book does show the ugly part of it, but it also shows the, dare I say, the fun part out of it, the living for now, the doing stuff, the making a difference with our condition. And that's so important. And we had another little book out which is Walk With Me, and it's basically, I'm not a poet, but I used to come up with little things that I would send to Debs in text messages about, I suppose, how my dementia was affecting me at that time. The key thing was that sometimes we can't always tell our close loved ones how we're feeling, because sometimes it's a little hard for them to hear it. But for a good friend to hear it, who is connected but not fully connected, Sometimes that makes a lot of difference. And these little poems and sayings are just little reflections on what it's like, little snippets, moments in my mind of how living with dementia is for me. And I think the whole idea is to educate people and try and make people aware. Try to make people lives better. And I don't just mean for people with dementia, because in actual fact, when somebody in the family is diagnosed with dementia, the whole family lives with it. It's a diagnosis for everybody and not just for an individual. And if educating people can somehow make everybody's lives a little bit better and a little bit easier, then that has to be a good thing. Well, I've spoken now for 25 minutes, and I believe 25 minutes is my time limit. So rather than Deb sitting there waving frantically at me, I'd like to say thank you very much for this opportunity. I hope I didn't bore you all to tears, and I hope some of it made some sense. And yeah, do have a look at the books. We also have a Facebook page, Peter Berry Living with Alzheimer's. That has all our stuff on, and a website and various other things. So please do look it up. There's a lot of information on there, and it's not a privilege to have this condition, but it's a privilege to be able to help others to understand this condition. So I suppose from a nasty condition comes a little bit of light, and that has to be a good thing. Thank you all for listening. Have a wonderful day. Bye-bye.
Well, thank you to Peter in absentia for such a lovely half an hour. Deb, are you on? Oh, there you are. I wonder if I can just ask how you and Peter first met. Was it through the shared love of cycling?
Yes, it was. I'd recently moved up from London to Suffolk, and we knew nobody. And I bumped into him in the local cycling shop. And because people in the country are really friendly, we started to chat and went out on bike rides, and it happened like that.
I was really struck by his humbleness, and especially that last thing he said, the privilege to help other people, which is, just, as I say, very humbling. But that's been your experience of Peter, his desire to help and to show people what things can be like.
It has been my experience. Obviously I didn't know Peter pre-dementia, so I don't know the man he was. But ever since I've known him, which is nearly 4 years, all he wants to do is to do things. If you say, Peter, do you want to? He'll say yes before you even know what it is. He just wants to help and share his experiences, because he did go to dark places. He tried to kill himself twice, and he makes no secret of it. He had the rope around his neck. He was that close. And he doesn't want anyone to have to go down that particular journey. So his mission is to help people, to give back to people.
We have a couple of things in the chat. Sarah has asked where you can get the book, so I've posted an Amazon link to the Slow Puncture book there in the chat. Dan, there's a question asking, is the video going to be available for a few days? Which I'm afraid I don't know the answer to. But if anybody has any questions that, as Deb is here, she may, that you'd like to ask her, I think probably the best thing is if you remotely put your hand up. If the chat's a bit slow, if you click the reactions button at the bottom, it should give you an option to raise your hand. So I'll just see if anybody wishes to pose any questions. No one coming up.
What I should say is that 25 minutes was obviously unscripted. He has nothing written down. And what I have noticed over the last couple of months is his flow is getting a little bit more interrupted, which is quite a depressing thing for me to see. But I still don't think I could talk for 25 minutes without a script. No. And not remembering what I said 3 minutes before. And to keep that flow going, I just find it extraordinary he can do that.
And I was struck by the absolute lack of frustration when you did prompt. There was no sign of frustration, just a complete sort of friendship and acceptance, which was lovely to see.
Yeah, I mean, I think so. I think he gives as much to me as I give to him in terms of bike maintenance and the routes, and I feel looked after, which I think is a nice way of turning it upside down. You know, man with dementia looks after slightly crazy elderly lady. You know, it works well, and he doesn't get frustrated.
And the term slow puncture from the book, which is actually, it has many meanings, and I'm assuming that was the reason it was chosen as the title.
It just seemed apt in looking at bikes and his condition. It seems a pretty good metaphor. Super.
Well, I've seen in the chat that there's going to be a way, with Peter's permission, to host the video on the website. So we will look at that to try and make it available. I'm going to hand over to my colleague at Dementia Jersey, Wendy Buckley, who's going to say a few words, but I just wanted to say both to Deb and to Peter, if you'd pass on our enormous thanks, because that was really quite marvellous.
I will, and he'll say wonderful, but he won't know what I'm talking about. But I will remind him. Thank you.
Thank you.
Okay, thanks.
Wendy.
Okay, good evening, everyone. Unfortunately, Claudine Snape, our CEO, who some of you might have met last night, is not able to be here today. So she's asked if I would just wrap up this evening's session with a few words. My name is Wendy Buckley, and I'm the Operations Manager at Dementia Jersey. I'd like to say some thank yous first off to Dr. Matt Doyle, who has hosted this evening, even with the interruptions with Dr. Melendez's speech. So thank you for that, Dr. Doyle. I'd also like to thank Dr. Melendez, who I think had to go for another appointment. So sorry if some of you didn't get your questions answered, but thank you for an inspirational speech. And also I would like to thank Deb for arranging for Peter Berry to have recorded such an inspirational talk, which I'm sure will have touched quite a few people's hearts this evening. Just a reminder to everybody who is listening, this is a CPD registered event, and I will be endeavouring to get everybody's emails to the CPD for them to send certificates to you. Should you not get a certificate in the next few weeks, please get in touch with us, because it's very difficult to get everybody's names from the way that you've actually logged on this evening. And as we're in Dementia Awareness Week, and we have arranged these online talks, I'd just like to remind you that the third and final talk of the week is tomorrow evening, where we're focusing on the role of the carer and what it is like to be cared for caring for someone with dementia. And our speaker, the first speaker in the evening, is Dr. Sian Waring-Jones, who will be talking on the role of a carer. And then we're very privileged to be joined by Jane Goodrick and Chris Roberts, who together are going to be looking at the challenges of living with somebody with dementia and that caring role. So if you've not registered already on Eventbrite, please do so. I'm sure that's going to be another inspirational evening. But I'd just like to thank you now for joining us and hope that the rest of your evening is a good one. Thanks ever so much. Bye now.
Thank you, everybody. Good night.